it is very important to consider that as many lines of treatment we can offer to a patient, the better is the possibility that this patient will have an extended survival and a better survival. Therefore, third-line treatment is very important for patients with metastatic colorectal cancer. And when all the previous options, including FOLFOX, FOLFIRIS, or the biologic agents used in these patients according to the RAS and RAF status, either anti-angiogenic drugs or anti-GFR monoclonal antibodies, have been used in the first 2 lines, and therefore the patient is considered refractory after the first 2 lines, the best option is to offer to a patient an alternative drug. Now we have 2 main options for these patients. The 2 options are either a multikinase anti-angiogenic inhibitor, that is Regorafenib, or an alternative relative to 5-FU, an alternative fluoropyrimidine, that is an oral fluoropyrimidine called the TAS-102 or trifluridine tipiracil. That has a completely different mechanism of action if we compare to capecitabine, that is another oral fluoropyrimidine, or to 5-FU that is given IV. And both Regorafenib and TAS-102 have similar possibility of offering a better survival in this purely palliative setting as third line of treatment. The main question is, which is my choice in terms of each of these 2 drugs in a patient after failure of the first 2 lines of therapy? Both drugs works better in patients that have a relatively long metastatic disease that had benefit from the 2 previous lines of treatment. In both drugs, the best therapeutic efficacy is seen in patients with relatively well performance status, and therefore patients in PS0 or PS1 will have much more chances of responding to either drug, Regorafenib or TAS-102, and therefore it's very difficult to see if there is a specific profile differentiating the 2 drugs choice. One possibility is to consider the different toxicity and side effect profile. Obviously, TAS-102 is a chemotherapy agent, and therefore the main toxicity is bone marrow toxicity with neutropenia and also thrombocytopenia. Whereas being an anti-angiogenic multikinase inhibitor, Regorafenib usually has the side effects of anti-angiogenic drugs, including potentially hypertension, and one specific side effect sometimes is precluding the use of Regorafenib for a long time is skin reactions and sometimes asthenia. Another important question will be, if in third line I have to choose between TAS-102 and Regorafenib, do I have some evidence that is better 1 or 2 regarding what happened with the previous 2 lines? Obviously, being TAS-102 a cytotoxic chemotherapy agent, if the patient in the 2 previous lines of treatment was heavily pretreated with chemotherapy agents and had bone marrow toxicity, I will prefer to use Regorafenib that has not bone marrow toxicity before TAS-102, and then I will use TAS-102 at progression after Regorafenib. On the other hand, if the patient experienced more angiogenic drug-related side effects, I will prefer to start with TAS-102 followed by Regorafenib. The key point here is that whatever we start first, it is really the most beneficial treatment choice for the patient, that we hope to have a sequence of the 2 drugs, one after each other. Actually, we have evidence from a series of clinical experiences from some early clinical trials that Regorafenib followed by TAS-102 or TAS-102 followed by Regorafenib are 2 good options for extending in the continuum of care the opportunity of active therapy regimens to these patients. Certainly, metastatic colorectal cancer is a very heterogeneous disease, so we are always looking at understanding this heterogeneity for finding potential biomarkers that can guide us to find the best selected or precision-based medicine-based treatment options. What we can say in metastatic colorectal cancer is that the first choice has been the knowledge of RAS mutations, because RAS mutations have been very instrumental for defining those tumors that were resistance to anti-GFR drugs, and so restricting anti-GFR drugs to RAS wild-type tumors in patients bearing these tumors. The second has been BRAF mutations. BRAF mutations are a very bad prognostic factor, but now they are a very important predictive factor for potentially active therapy against the BRAF mutated axis. More importantly, we have some other biomarkers that can guide us. One is still in terms of biomarkers linked to growth factor pathways, and this is the amplification of HER2 gene. This is a rare gene alteration because about 4 to 5% of RAS wild-type metastatic colorectal cancer patients have a truly HER2 gene amplified cancer, but in these patients we have evidence that a selective anti-HER2 therapy, similarly to what we do in breast cancer in HER2 amplified breast cancer patients, could be of very important benefit, at least for chemorefractory patients. More recently, with the introduction of immuno-oncology and immunotherapy drugs, including the immune checkpoint inhibitors, a lot of attention has been given also in metastatic colorectal cancer to define which of these patients could have a benefit by immuno-oncology therapy. Unfortunately, I should say that today, about 95% of patients have a tumor in which maybe the immune functions could not be restored by treating alone with immune checkpoint inhibitors such as PD-L1 inhibitors plus or minus anti-CTLA-4 inhibitors, because these tumors have a relatively stable genetic alteration, so that is also reflected at what we call microsatellite stable genotype, whereas about 5% of tumors, more often for a mismatch repair gene deficiency, have what we call microsatellite unstable tumors with high instability, or MSI-high tumors. In this case, we know that we have very strong evidence, at least in second line, and now we are looking for data for first line treatment with PD-1 monoclonal antibodies such as nivolumab or pembrolizumab, or even combination of PD-1 monoclonals such as nivolumab plus anti-CTLA-4 antibody ipilimumab could be of great value for these patients. So the era of defining better potential biomarkers for metastatic colorectal cancer has just started, and with BRAF story, we are adding another important piece in this story.